Good evening, everyone, and welcome to another session. Thank you, Pride. Good evening, everyone, and welcome to another session of Intellectus Campus. And our focus is on medical management systems, following on from last week. Now, last week, we discussed a capitation system that would be able to provide affordable care through GPs, through nurses, and through specialists. And this week, we're following on from it to start introducing a bit of out-the-box thinking. And in accordance with our previous themes, we want to get away from a one-way system of doing things, which at the moment is a fee-for-service model. And we want to also look at African solutions for African problems. So Dr. Nasir Syed, we recorded him yesterday doing this presentation. He's going to focus on bringing specialists into the primary care space. And in accordance with last week's discussion, we would envisage that as a virtual or real group of GPs with subspecialties who might bring in 1 day a week a cardiologist or a physiotherapist or somebody who would come in to complement a clinic. And that clinic could be a diabetic clinic, it could be an asthma clinic. There's a multitude of ways that this could occur. So I'm just going to go, before I formally introduce Dr. Nasir Syed, who many of you know already, I just want to go through the possibilities. And one of the things we've also had as a theme is all of the proof of a pudding is in the eating. So if we look at not being theoretical, if we look at being real, what has worked in the past and how has it worked? And how do we discuss around a table what different doctors have tried and what works? So what I personally have seen in the past is a state capitation system. So I trained in South Africa. And a state capitation system means you're paid a salary, but when you do your internship, you're paid almost nothing, but you're paying to train. So it's a bit like an apprenticeship, and it does work, but it's not very good for staff retention because people cannot survive on that as doctors. And there's some very interesting articles looking at the Australian Medicare system, where doctors can't afford mortgages and school fees based on Medicare bulk billing. And so they go into a fee-for-service system. The fee-for-service system works very well when the capitation service is not working well. And we know that from Zimbabwe, when the public health system fails, then people are prepared to pay for healthcare. I've seen it in Dubai, Australia, and the UK, but the danger of the fee-for-service system is that doctors are paid to keep people sick. So it suits a doctor if they see a patient 5 times rather than sorting it out once. Privately designed, owned, and managed capitation systems, in my opinion, are the ideal. I saw this work in Dubai. At Emirates, what they did was, because of over-servicing of the aviation crew, which sometimes led to loss of license of pilots with unnecessary arthroscopies and unnecessary screening colonoscopies, which resulted in one case, contracture of the knee, and in the other case, adhesions in the abdomen. It cost $250,000 to replace a pilot. So it was in Emirates' interest to employ doctors that didn't over-service. And then as it grew, people employed specialized generalists. So when we had 30,000 cabin crew, many of whom were Muslim, we needed more female doctors to do pap smears. When we had a lot of sports injuries, we needed, and we were referring a lot to orthopedics, we simply brought in more sports medicine trained doctors. I also saw the system work in Australia, in a place called Strathaven, and we have a Strathaven here. We saw it work by putting all the generalist doctors on the ground floor with the receptionists that knew who specialized in women's health, who specialized in acupuncture, who specialized in headache, or whatever the condition was. And if you have a good booking system, the patients will select the doctor that they want. There was also a little town called Yankalilla, and what they did was they had 4 or 5 generalists, and once a week they would bring in the physio or the psychologist or the allied health specialists to come to the practice, and the generalists would book that person for the whole day. And that person, if they were coming in remotely, like if they lived an hour away, could see the doctor and the psychologist on the same day. So that system also works very well. The advantages of these systems are that it's a one-stop shop for the patient, so it becomes popular, but also the specialists start to train the generalists. And it's very easy to walk across the corridor or pick up a phone if you have a specialist on site. Now, with Emirates, the interesting thing was that doctors were well paid to keep the crew in the air. The airline did not start a medical aid system. They wanted their staff as fit as possible. So we had wellness programs, we had prevention programs. We taught crew what to do when they were going to a malaria area, and we vaccinated against various diseases, including yellow fever, hepatitis, and those kind of things. The important thing was that the clinic bonus depended on how little we outsourced. So we self-policed, because if one GP was referring left, right, and center and taking out of the budget, the other GPs would come in and say, can you please stop doing that? Because we're actually working very hard to not outsource. And the individual bonuses and the individual salary rises were based on key performance indicators, which included how little sick leave did you issue, how little did you hospitalize, how little did you refer, and how many aviation licenses and lives did you save. And it's probably the job I've enjoyed the most. So how do we outsource specialist care? We either employ generalists with a subspecialty. We already know in Zimbabwe which doctors like women's health and which doctors like pediatrics and which doctors like diabetes. And these doctors very often have a diploma, and Intellectus Campus will hopefully progress towards giving diplomas in subspecialties. So what we did as a clinic was, when we needed another women's health doctor, we went out and recruited somebody, and it saved us a lot of money. We also trained nurses to do pap smears, and nurses were trained in either women's health or infectious disease or in aviation medicine, and they were able to take on a lot of the work of a doctor, which allowed the doctors to do more interesting things. And it also allowed the specialists to do what specialists are allowed to do, because instead of seeing people that generalists could handle, they would see the highly specialized stuff, which they enjoyed. So from a job satisfaction point of view, that definitely works. You can also, as I've said, bring in specialist doctors who work alongside generalists, and Dr. Nasir is going to actually discuss the evidence behind this. And we must remember that allied health and complementary health, if you run a diabetic clinic, you're going to want a podiatrist there. You may want an ophthalmologist visiting for a day. You may want to have a nutritionist there, and you may want to have a diabetic nurse there, which stops the doctor from having to repeat themselves over and over again. The other thing, when you do a specialist clinic alongside with generalists, what you can actually do is put 10 patients in the room at once and only discuss diabetic diet. So you might have the nutritionist and the doctor there, and all of the patients ask questions, and then the answer to a question will answer another patient's question, and they form an automated support group. So these are ideas that we can discuss at the end of this meeting. Post-COVID, we have discovered the power of virtual group practice, virtual consultations, and we do this already. We do WhatsApp consultations with patients, we do Zoom consults, but we're also able to Zoom in a specialist. I recently had a 2-hour session with a cancer patient who was talking to the specialist gastroenterologist, the oncologist, the nutritionist, and in the mix was also a psychologist. And everybody learned a huge amount. The patient got 2 hours of time, and the people around them got 2 hours of teaching. The ideal will also be to start doing group grand rounds, which can be virtual or can be in reality, and we can attach continuing medical education to that, which resolves a lot of doctors' issues with CME. But in this kind of case, you really are learning and you're doing patient care at the same time. As we've discussed, the only way we can do this is a team and stay ahead of it. In our current state, can you please mute your mics? Our current state is of a fee-for-service program, and we have a good idea of what our future state will be. At this point, I'll introduce Dr. Nasir Syed, who is a primary care physician, and he has been part of tuberculosis research trials across Zimbabwe, South Africa, and Botswana. Alongside his role as a trial physician, he is a senior partner in Harare medical practice and has extensive experience in positions including medical superintendent, district medical officer, and many others. He also holds a postgraduate diploma in tuberculosis and chest diseases from Karachi University and is recognized for his contributions to the Zimbabwe Medical Association and his commitment to advancing medical knowledge and patient care. So with that, I'm going to stop sharing my screen and I'm going to ask Pride to play the recording of Dr. Syed, and then at the end of that, we'll have a Q&A session. Thanks very much. Good evening, Dr. Nasir, and thank you for presenting this. I'm handing the floor over to you.
Thank you very much, Jackie, and I'm again very privileged, very honored. I feel very happy that Invectus campus has allowed me to present once again. And good evening, ladies and gentlemen. My heartiest greetings to all my audiences. So today's topic is bringing specialist care back to the primary care subspecialist arena. So we'll start our presentation. It's a very important topic and is very close to all of us, especially us who are in the primary care. Now, what is primary healthcare? I don't have to explain it to we all because we are all actors in this huge, which impacts everybody in their daily life, wherever they are in private or public. Primary healthcare is the mainstay of health. Just to give us a small recording of that, the primary care encompasses a wide range of healthcare services, including preventive measures. We can all give us a pat on our back. Well done, primary care physicians. Now, just a small reminder to the audiences. What is primary care? So it integrates the health services. It addresses determinants of health. It empowers individuals and communities. So how it does integration? It health promotion, disease, prevention, treatment, rehabilitation, palliative care, addresses determinants of health, social determinants, economic and environmental. It empowers individual communities, creating awareness, telling them what to do in the situations when need arises. So like an educational support. A little bit detail about primary health care. So as I said earlier, disease prevention and screenings. So health history assessment. We all aware that primary care doctors review the health history of the patients and they identify risk factors. They administer vaccinations to prevent diseases, and they regular screens diseases like diabetes, cancers. Then the acute healthcare, you can twist your ankle, you can break your forearm, you can break your femur, you can have a very anything emergency attended by the primary healthcare people. Then the chronic condition management, we are all aware that diabetes, diseases like hypertension, bronchial asthma, and the list goes on. And as I mentioned earlier, community awareness, that doctors remain informed about local health issues outbreaks, they keep themselves abreast, and then they spread it to the community and they affect the well-being of the general public. So once again, provide continuous care for people of all ages, backgrounds, and conditions, care for entire families from birth through the end of life, and advocate for healthy lifestyle changes and addresses chronic problems. I'm sure a lot of you who are in primary care would be seeing the second, the third generation now of patients, and they feel very pride. And then when they come to you and they discuss your issues, and sometimes when there's a locum doctor in your place when you're away or you're on vacations, and they are not very comfortable with other person, they would like to you be there. It happens to me, and I'm sure it happens to all of us. Patients relate to you, which is the mainstay of our practices and the mainstay of primary care. So the primary care doctor also serves as the entry point to the medical system and can guide the patients to the most appropriate specialist when need arises. So the question arises, why bring specialist care to primary care subset specialty? Are the primary care doctors not enough, or they are not enough qualified? Are they not experienced? Answer would be no. They are definitely good qualified. They are very qualified. They are very experienced, and they are very close to the patients they see, very close to the locality or the community where they practice. Maybe it's government, maybe it's private, but they are there. So why bring this topic? Why bring specialist care to primary care subset specialty? So there are 5 most important factors when we bring in the specialist care integration into the primary care. Improved access, holistic care, cost effectiveness, reduce referrals, patient-centered care. Let's look at all these things in detail. So what do we mean by improved access? So by having specialists available in our settings, patient can receive timely consultations and expert advice without needing to visit separate specialist clinics or hospitals. Holistic care. So we integrate specialists, allowing for a more comprehensive approach, and they can provide collaboration to address both general health and specific conditions. Cost effectiveness, very important issue, especially in the underdeveloped world. Early intervention and management of health issues at the primary care level can prevent complications and reduce overall health burden. Here I would like to mention at the Primary Care College of Zimbabwe meeting today, there was a specialist surgeon, and he mentioned that we are not mentioning the exact name of the institution, but he mentioned a insurance institution which is emphasizing on early screening of people for colorectal cancer, and they are actually like investing in that thing. They are emphasizing more and more people get screened, so the burden of so that they catch more cases earlier, good treatment, and less burden. That's a great benefit, but it's still it applies to us. So reduce referrals. We are all aware the central hospitals in any country, in any city, in any districts are overburdened, and the doctors are really under a lot of pressure. They're working under tremendous duty hours. So when the specialists work alongside the primary care providers, there would be no unnecessary referrals to secondary or tertiary care, and it will be minimized. And this will streamline the patient's journey also. Patient-centered care. Once you have a specialist in primary care, it ensures that patients receive personalized, coordinated care, which considers unique needs and preferences. I'm sure my colleagues are following this. So the collaboration of the specialist in the primary care can work in several ways. Consultations, of course, when we will consult, the primary care can seek expert advice from them time to time, and they will help in managing complex cases and making a timely and informed decision in many diseases. Shared care plans, collaborative care involves both primary care providers and specialists. They will outline treatment goals, they will set the treatment goals, the responsibilities, and the follow-up procedures. Case conferences, regular meetings where primary care providers can present their cases and they can discuss their cases with the specialist. They can share the insights and the coordinate care. Referrals, so it will be like a necessary referral. They will not be unnecessary referrals. Very essential, which will help in the further evaluation and treatment. Then the newer things are coming into the arena is like the telemedicine, where virtual consultations will allow real-time communication between the primary care and the specialist. So if you look in whole of all this slide, you'll see it's preventing the burden on the specialist and the tertiary and the central hospitals, especially in our settings, which are overburdened, overworked. It will really of benefit not only to us, but them also. So in summary, when we bring in the specialist expertise to the primary care, it will enhance the quality, the accessibility, and the efficiency of health services. Having said that, it's not that easy. It's very easy to present all these points, and then we say 1, 2, 3, 4, 5, and let's bring the specialist care. So in every project, whatever we do in our life, we face hindrances, and there are hindrances in this topic also. Let's look at them. What are the hindrances faced if you try to incorporate the specialist care into the primary care? Limited resources, resistant to change, hierarchical structures, differing priorities, time constraints, communication gap. So if there is an effective collaboration, what are the hindrances we just mentioned? And let's look at them in a little bit detail. So what are the gaps? Lack of clarity in communication channels, miscommunications, leading to misunderstandings and delays in patient care. Differing priorities. So the primary care providers and specialists may have different priorities and perspectives. It will definitely affect the collaboration. Time constraints. Busy schedules can limit opportunities for face-to-face discussions or joint case reviews. Hierarchical structures. Hierarchies within healthcare systems may discourage open collaboration. Limited resources. We all know insufficient fundings. They can also impact the collaboration. And definitely, we live in environments where are definitely some part of communities or in specialists also, there will be resistance to change. They will resist to adapt the collaborative models because they already have the established practices and they have established principles. So it will affect the collaboration. Now, if we can addressing these barriers, it will require proactive efforts, such as promoting effective communication, fostering a collaboration. This is a very important slide my colleagues will appreciate. Here I've shown you world-renowned trademarks, and they are already established billion-dollar economies, billion-dollar industries. They incorporated some specialists into their systems, and the results was phenomenal. Let's talk about Amazon. Everybody knows about Amazon. In the first world, I think every household every day orders from salt, pepper, chilies to poultry to other meats, TVs, computers, ballpoints, anything, you name it. Amazon is there. So why would Amazon collaborate with other things? They collaborated with Whole Foods Market, and their grocery delivery and sale became triple and more efficient. Who doesn't know about IBM? They collaborated with Maersk Lining, a very big shipping freight company, and they streamlined their logistics. Digital platform was formed, which tracks the ships, the freights, delivery, everything was really phenomenal. Then Samsung and Oculus. Samsung Oculus combined, and then the result was the children and the teenagers love it. They call it virtual reality glasses, and it's really wonderful. The sales are very high. I'm coming to the very famous Starbucks coffee. We all had a coffee of Starbucks somewhere there, and all the present teenagers must be listening to music on their telephones or their tablets on Spotify. The Starbucks combined with Spotify, and it gave a very good ambience in Starbucks in-house customer care. The sales also became higher. Similarly, let's talk about Tesla and Toyota. We all know about Toyota, the world's top car maker, automobile maker, and Tesla, the first electric car. Toyota collaborated with Tesla, and they resulted in new and more efficient electric cars. Microsoft. Now we are working on Zoom. Zoom is owned by Microsoft. In Adobe, we all are very aware, it's a document efficiency software. So Microsoft collaborated with Adobe. And Microsoft, when collaborated with Adobe, it streamlined the documents. They're sharing, they're streamlining. NASA, the World Space Authority, World Authority on Space, they collaborated with, Google. And it resulted in quantum AI lab. I can't say much about it, but it's a real invention, and the quantum lab AI will make our space adventures come true. So you can say that I was giving you business examples, but these examples can fit into our world also. That these principles of successful partnerships can apply to the primary specialist collaboration as well. How? And I'll give you an example of a health system participation, and you can look at the result and you will appreciate this. There's a Michigan Collaborative Quality Initiative, and these collaborations among dozens of hospitals and physicians in Michigan have achieved impressive results in areas as cardiothoracic care, bariatric surgery, blood clot prevention, joint replacements, and urology. Similarly, there was a PPS integration into primary healthcare internationally done. Amongst them was United Kingdom, Asia, there was Pakistan, Iran, Cambodia. In South America, there was Brazil, United States, and in Africa, Nigeria. And these PPPs, public-private partnerships, you can say that specialist partnerships facilitated access to the PH service, and it helped in the maternal and child health, family planning, immunization, and health promotion. So these successful public-private partnerships, or you can say the specialist partnerships into primary health care, when it was implemented in health education promotions, covering areas like oral health, sexual health, screening programs, and nutrition, results were very good. So you see that business model worked in health also. So we need collaboration, efficiency, innovation, patient-centered approach, and technology adaptation when we integrate the specialist care into primary care. A little bit in detail. So as I mentioned earlier, successful partnerships, healthcare should foster collaboration, share goals, and open communications. These are very essential to make the collaboration successful. There should be innovations. They will lead to innovative products or services. You saw yourself how the McDonald's and Coca-Cola sharing, branding, it improved. It will also improve in the health services. Innovation will come into our services. Healthcare innovation will improve. Efficiency definitely will improve. There will be unnecessary referrals. We mentioned it earlier. Patient-centered approach and successful partnerships, customer needs, and it will focus on patient-centric care. So if you remember that successful partnerships thrive on clear objectives, open communications, and collaborative leadership. Though it's not a dry topic, my audience would be following me where I'm taking you. This is another slide which shows how the collaboration works. So there will be some frameworks established, some incentives, some training and education. Will need some data sharing, will need team-based care. This is very important. Team-based care, because there will be multidisciplinary teams that will execute the collaboration, and there will be nurses, social workers, other health professionals, and they'll be supporting both primary care and special services. And community has to be engaged. You cannot achieve any target without engaging the community because they are affected, definitely. So successful prioritized patient-centered care, efficient workflows, and effective communication. So in medicine, you have to talk about evidence-based. So I'm giving you an example of a paper, which is a specialized care to the primary level. And I've given the link also. We'll share the slides also, so you can go on the web and have this is an open paper, so you have access to this paper, and it will really enlighten your knowledge about if the specialist care is integrated into the primary care. One most important thing is the policymakers, especially in our settings. The policymakers are the crucial people. He is the one who has the key in his hand, and these policymakers in the health sector, they have the last say. So they are the ones who will help us achieving this goal. So what are the roles of policymaker? How does he hold the key? Because he has the funding and the resources. If he allocates enough funding and resources, primary healthcare strengthens. But many times we see in many countries, the funding and resources to the health sector are always lesser than other departments or other ministries. If you talk to any health minister of any country, he'll be moaning about that we don't have enough funding. So there should be, and he's the one, the policymaker is the one who can give an incentive, who can give a reimbursements model, to design payment models, because they have access to the funds, as we said earlier. Then workforce planning. So workforce planning plan for an adequate supply of primary care providers and specialists, encourage recruitment and retention in underserved areas. Quality metrics. So it defines the performance metrics that assess collaborative efforts, monitor outcomes, and adjust policies accordingly. Community engagement, as we mentioned earlier in our talk. Communities in health planning understand local needs and tailor service accordingly. So by aligning policies with collaborative goals, policymakers can create an environment conducive to effective primary specialist partnerships. So there is an evidence-based research, data-driven decisions, impact assessment, transparency, continuous learning. So we throw the ball into the court of the policymaker. So there are some global best practices also. which are still being done. And I gave an example of the Michigan things. Here is strengthened institutional networks with WHO collaboration. They are playing a very crucial role in generating evidence for health policy. Then, as I mentioned earlier, transparency and trust, then collective health protection, knowledge sharing, and equity. And equity will promote enabling voices from low resource setting to be heard. And it will facilitate collaboration and learning within and across regions. It can be challenging because of the lack of knowledge and skills, time management, motivation, resource constraints, training needs, and all these challenges has to be addressed, especially funding, staffing, and infrastructure. One more important thing which we need to be collaborated into the primary care is the clinical guidelines. We shouldn't forget clinical guidelines bridge the gap between evidence and practice, leading to better patient outcomes. And clinical guidelines definitely are the forte of the specialist. And they are the ones who will bring the clinical guidelines and implement them in their practices and also pass on to the primary care providers. So as I mentioned earlier, clinical guidelines standardization, they standardize the recommendations on the diagnosis, treatment, and management of specific conditions, general health care. And once you have standardized your treatment guidelines, the treatment of specific disease becomes very easy and is manageable. Then you don't let physicians do what they want. They follow a guideline, especially in conditions like HIV, conditions like tuberculosis, and most infectious disorders in which you have to follow a local guideline pertaining to that particular sector or department or the country. We must follow the guidelines. Then the synthesis of the evidences, because they are based on the evidence, and when we follow the guidelines, as I'm saying, it will improve the quality of care. And decision support, when we'll use the guidelines, your decisions will be very clear. Not only help you, make you happy also, and the patient care also becomes very good. And these are the best educational tools for the health professionals. I mentioned this earlier, there will be multidisciplinary teams, including physicians, nurses, midwives, dentists, physiotherapists, social workers, pharmacists, and administrative staff. And then the specialized teams who will deal with some specific conditions like type 2 diabetes, type 1 diabetes, and other things. Patients also play a crucial role in the guideline adherence. We shouldn't forget that. Patients should understand the guidelines provided by the healthcare providers, so the clear communication is very essential. The participation of the patient and the community is very important in decisions. Self-management, feedback, providing feedback to the health professional about their experience with adherence. This will help refine care plans. So in summary, patients are a very important partner in their own healthcare journey, and adherence to guidelines contribute to better outcome. We shouldn't forget about nurses. They will form a very important role, and Dr. Stone will agree with me. She's very vocal in nurses' education and nurses' care, that they play a very, very pivotal role. Without them, I mean, the physicians are definitely worthless. We need them, and they are the backbone of the health. So when you are integrating specialist care into primary care, the nurses will play definitely a very important role. They will collaborate with they can form a bridge between a specialist and a primary care physician. They work in various settings, as we all are aware. They work as community health worker, they work in general practice in private, or they work in central hospital, tertiary health centers. They manage a wide range of health issues from routine checks to chronic conditions. They contribute to early detection and disease prevention and patient partnerships. So definitely the nurses build sustained relationships with patients. They engage in shared decision-making and empower patients to manage their health. I'm sure the nurses will be very happy with this slide. So let's summarize our primary health care. So people-centered, physical, mental, and social. At this slide, I would thank you very much for listening to me, and my gratitude. Thank you to Invictus Campus once again for letting me do this talk, which is a very important talk. I'm open to all questions, and we'll share our contact details. If you have any queries, you are most welcome. I'll be more than happy to come back to you. And let's hope that we would integrate. Before I finish, I would like to mention that there is a program for family medicine run by the University of Zimbabwe. It's an MED program. It's called MED Family Medicine. And Dr. Edward Chagonda and Dr. Billy Rigawa are the backbone of this program. If you want to get in touch with them, Dr. Chagonda especially works in the UZ. He is in the Department of Primary Healthcare unit. He is the backbone of the family medicine program. If somebody is interested in specializing in family medicine, definitely this is the time. And I would request my fellow colleagues, if they have the opportunities, one of us should please join this program and they become a part of the subspecialty. Thank you very much. Good night. Thank you very much.
Thank you very much, Dr. Nasir, for a very enlightening presentation. You know, I've had the privilege of working in some of these settings, and after last week's presentation, it works best with a capitation model as opposed to a fee-for-service model. And one of the advantages of getting into bringing specialists into primary care, especially if you have a group practice, whether it is actual or virtual, what you end up doing is it becomes very easy as the primary care doctor to pop across the corridor for an opinion. And then because you're getting opinions from the cardiologist who's there on the day, or the neurosurgeon who's there on the day, or the back specialist, you learn from your own patients. And then the group practice tends to evolve into the doctors that are interested in sports medicine start taking over the simple orthopedic cases. And then the doctors that are interested in diabetes start working with nurses who are interested in diabetic care, and they form their own subspecialties. So more and more and more, the specialist, it's a skills transfer. The specialist transfers the skills to doctors in their individual areas, and then it evolves into a situation where the doctors will then refer to the doctor that is subspecialized in an area, and only then does it need to be escalated to the specialist. And the nurses that get well trained in this then become much better at triage. So the whole system becomes very patient-centered. And where I used to work in Queensland in Australia, we had the bottom floor was primary care, mainly GPs, but each GP had a subspecialty. So you had your guy who did acupuncture, and you had the lady who did all the pap smears. And then the reception staff become skilled in finding out what the problem is and who to sub-refer to early, which makes things much more efficient. So if somebody sends me a prostate patient and I say, I'm sorry, I've done 30,000 pap smears in my time at Emirates, but prostate, I can automatically screen at reception level. So it becomes a self-building system. And the bricks start at the bottom, and the GPs get more and more subspecialized, and the specialists are then occupied with things that interest them. And the skill transfer is quite remarkable. And I really think at policy level, we should try and drive this. And the other thing I wanted to mention is that integrative medicine is going to be the theme for 2025, and Zimbabwe will hopefully lead the way in that. And in terms of patient choice, we can start bringing in the homeopaths, the acupuncturists, people who are involved in natural medicine, the psychologists, the dietitians, and everybody else into this. And then if you start doing that as well, skills transfer goes both ways. So there's a lot of controversy over people who advertise their skills when they may not have a medical degree. But if we can teach those people to clinically examine and skills transfer, at the end of the day, as Dr. Landman has said, if you focus on the best possible patient outcome, I think this is the way to go.
Yeah, I agree with you. That you are very vocal about nurses. In my practice, I trained one of my nurses, and I sent her to a few courses also and a few workshops also on diabetes. She's so happy with it, and now it becomes my job has become so easy. If I see a patient with type 2 diabetes or type 1 diabetes, and then I refer to her, she spends hours with them telling about diet, exercises, compliance, and then we see the results. And she has taken my 40% of my work.
Absolutely. And it's all about skills transfer and patient outcomes. So thank you very much for that.
That's definite. That's the word, skill transfer. Yes. Yes, I agree with you. Yeah.
So with that, I'm going to end the recording, and we'll open everything up for questions to the floor. And thank you, Pride. I'm going to just share my screen again. And I'm just going to go back to what we said a little bit earlier, which is the current state and the future state and how we get there, because it's all very well to talk about this. But if we can't actually execute it, then there's no point in talking about it. So the future state, we're really at the analysis and the strategic stage. So the analysis is, I would say, and I'm happy to be contradicted on this, but I would say that primary care and the patient-centered care is in trouble under the fee-for-service model. And I don't think many people would argue that there are less and less patients able to pay for medical aids, and there are more and more doctors competing for it, and it is not creating a healthy environment in sub-Saharan Africa. I know Namibia is having very similar problems to Zimbabwe. We know already, we've identified Access Medical, and there are other schemes, including Ultramed, who can provide an affordable solution that will pay a capitation fee to generalists, and that does not mean doctors only. There are many generalists practicing out there, which include nurses, traditional healers, herbalists, people who are natural therapists, acupuncturists, chiropractors. All these people are operating in silos. If we could bring them in under one umbrella, we could keep patients well, and we could collaborate, and we could do skill transfer. And the specialists can be incorporated into this model, and so can people who subspecialize. We can also bring radiology and the laboratory back into the consulting room in a one-stop shop using point-of-care testing, both point-of-care ultrasound, which we can train on, and also point-of-care laboratory testing. So that's our analysis. What is our strategy? Well, our strategy needs to be to identify those generalists and those specialists who are interested in what is called now in Australia patients before profits and a collaborative model. And the email address health@intellectuscampus.com should be live. And we can, if you email that as a person who's interested, we can start getting a group of doctors together. We already have at least 10 practitioners that are interested in this. We can also, in terms of partnerships, we can partner Intellectus Campus with Access, we can partner Intellectus Campus with government institutions, and we can partner with any GPs and practices in the area to create a virtual medical practice. And we can coordinate it so that we can actually provide CME while doctors are discussing case histories in a boardroom. And we can get that accredited through HPCNA as the easiest route, because it then has reciprocity with Germany. We can also, there's a group called the World of Wellness. I'm on the scientific advisory board there in Australia. And if we can get accreditation of what we do through Australian CME, then we will also be doing very well, because we can start bringing in the diasporan doctors into a virtual practice, and many are very interested. We can identify a managed healthcare system that provides affordable care. So what we need is 3 groups. We need to identify the generalists and the specialists. We need, as Intellectus Campus, to coordinate it, and then we need to identify the funding system, which ideally should be doctor-led, which Access does. And we must accept that we will learn as we go and custom build a new system, starting with Access and ideally starting with students who will be a pilot project. How do we execute this? We've given you the email address. Access will ensure they have all the regulatory requirements in place. We do not want to compete with medical aids. We are looking at a market that is not the 15 million people in Zimbabwe. Most don't have medical aid. More than 14 million don't have access to healthcare. And we will liaise with groups who cannot afford adequate care, with a focus on integrating the care of patients in a patient-centered model that is collaborative and inclusive of everybody that the patient sees. Our doctors and nurses are hemorrhaging overseas, and we think that it's better there, but the NHS is in a mess. This is what they're saying about Medicare at the moment. And as doctors can't pay their mortgages with impossibly low bulk billing allowances, and people who are injected in Australia become immune dysregulated, the casualties are being completely overwhelmed. In terms of themes, I've had a discussion with Professor Maponga, who is at the University of Zimbabwe, and integrative medicine under our constitution, under section 33 of our constitution, which I suggest you read. It allows for many health practitioners to operate, and we need to not only integrate all levels within the allopathic world, so specialists, subspecialists, and generalists, but we also need to integrate natural therapists, because by not speaking to each other, we cause division and patients use either or. We should all be working together towards patient-centered care. So with that, I'm going to just check the chat, see if there are any questions, which I can't see at the moment. Are there any hands raised? And Dr. Nasir, I can see you on the call. Do you want to come on? I'm not getting. I think he's got quite poor signal, and I think he's struggling to connect. We have 4 minutes to go. Are there any questions or comments? No? We've had a thank you, which is great. And I think the thing to do is to ensure that people who are interested join. This session will be recorded and it will be posted tomorrow on various doctors groups. So you'll be able to access the email address, and anybody who is interested, we're hoping as Intellectus Campus to partner with GP practices around the country and in the region with time. And we're hoping to be able to coordinate. I don't want to call it a medical aid, I would call it a medical fund. And we would like to be able to provide care, patient-centered care. So, Sibusiso, you've asked how you replayed today's lecture because you've missed some of it. What I will do is I will share on the SADC platform, I will share the recording as soon as the session ends. I understand that a lot of people do have poor reception. Okay, and so with that, Pride, can we stop recording?